Now looking at this case, which is presenting with recurrent episodes of paraparesis. Like I told you, when I'm scrolling the T2 sagittal images, I'll be trying to identify where the abnormality is. So I can see that there are some mild degenerative changes at L4, L5 and L5S1 levels. But more than these, again here also end plate changes and all are there. But apart from that, I'm able to appreciate that the lower portion of the cord and conus, there is significant expansion and also T2 hyperintensity. So I'll try to see the other images also. So these are the thoracic spine images where I'm able to clearly appreciate that the main pathology is in the spinal cord. The lower thoracic cord and the conus, there is some expansion also, and uniform or homogeneous T2 hyperintensity is seen. So before concentrating on that area, I just want to screen the rest of the areas so that I'm not missing any other area of abnormality. So now I'm sure that there is main pathology is in the spinal cord and conus region. Now I would like to see the stir images. So on the stir images, I'm able to appreciate same finding, and the rest of the vertebral bodies adjacent areas are completely normal. Only the spinal cord area is showing some significant hyperintensity. These are the T1 images which are not showing much of abnormality. So let's take a look at the T2 axial images. So on the T2 axial images also, I'm able to see that the entire cord is involved with very relative minimal sparing of the periphery in the higher portions. Whereas at the lower levels, the entire cross section of the cord is involved, and I'm not able to see anything else. It is predominantly homogeneous. Beyond that, there is mild expansion also. So this is almost similar to the previous case that where we have seen MOG type of demyelination involving the conus, and during the acute complaint there is mild expansion also. So in these kind of cases, it is very important to rule out one entity, that is the dural AV fistula. So in these images, obvious flow voids are not appreciated. In the other case that I have shown you, obvious flow voids are seen so that it is easier to pick up on the T2 imaging itself. When you are not able to pick up obvious flow voids, it is very important to do the fiesta imaging. Without fiesta imaging, you may miss out completely on the prominent flow voids. So here, this is the fiesta sequence. So on the fiesta sequence, I'm able to appreciate in the thecal sac, just below the conus level, you are able to see this corkscrew kind of arrangement. Multiple small flow voids are there along the conus area extending into the thecal sac. This is very important and subtle finding to appreciate. Unless you do this sequence properly, you may not be able to appreciate this abnormality. So this patient had a prior scan 1 year before in a local hospital, which was labeled as demyelination, and the demyelination workup was negative, and the patient symptoms improved normally. Because of that, he didn't approach any other hospital, and after 1.5 years, now he came because of recent onset of again the same similar symptoms. So whenever you are looking at homogeneous T2 hyperintensity in the cord, it is extremely important to look for the vascular malformations. As in this case, it can be extremely subtle. By doing the fiesta imaging, only then you will be able to appreciate this abnormality. So this is a case of conus medullaris dural AV fistula. So in these cases, what happens is there is abnormal communication between the arterial and venous channels. Secondary to that, there is increased blood flow into the venous channels, leading to congestive changes in the spinal cord. So these are basically edema changes. Because these are edema changes, secondary to venous congestion, they will be homogeneously hyperintense. You will not find any heterogeneity in these areas except when there is bleed component, which is extremely rare. So when you see homogeneous T2 hyperintensity in the spinal cord, before labeling it as demyelination, make sure to rule out dural AVF. This is the takeaway from this case.